such a pleasure to be here. And I can't tell you, first of all, thank you for allowing me to do this remotely. I was just at Stanford and I'm flying back out next week. And so it would have been 3 flights in 1 month. And I appreciate the flexibility. I also have been just so thrilled at the idea of coming here because you are pediatricians. And I'm going to tell you about why I think your role in inclusion is critically important. You've already heard, you've already heard all about me. Do want to mention that I do work with the ACGME on the Equity Matters campaign, and I'll talk to you a little bit more about that in a second. Together, we're going to talk about many topics, and I'm going to challenge some assumptions, and I'm going to challenge you to think a little bit differently today. But when we leave our time together, you'll be able to describe the benefits of employing and training physicians with disabilities. You'll also be able to recite the requirements of the ACGME as far as program and institution and disability inclusion are go. And then we'll ask you to assess your program and think about what you are doing or what you need to do to be more inclusive for people with disabilities. Okay. So when you were a child, did you dream about being a physician? I want you to think about that for a moment. And were you supported in reaching this goal? Did you have people that looked like you? So this could be applied to a multitude of identities, but were you able to see role models? Did you see people like you working in medicine, which is really critically important? And were you encouraged to become a doctor? When you finally vocalized that you wanted to be a physician, did people encourage you? So I think one of the memories that we often have is to be encouraged to explore different identities, right? And for you, part of that is being a physician. But people with disabilities may actively actually be dissuaded from entering medicine. And you as pediatricians are one of the first role models that children will actually see. They look up to you. Mentors for people with disabilities are few and far between. And unfortunately, the prevailing message about medicine is that in order to be a physician, you need to be a superhero of sorts. You need to be able to leap tall buildings in a single bound. And you need to be able to do this with no sleep, not eating, and never seeing your family or friends. So you might ask yourself, to people that aren't in our world of medicine, what does a physician look like? What does a doctor look like? What messages are we sending children? And are they told, and are the messages that they're receiving, that they could actually enter medicine? We need to challenge the existing physician model. And, you know, in the 21st century, the knowledge and skills that are required are very different from what they used to be. We know that research shows that diversity contributes to creativity and the development of problem-solving skills. So a more diverse workforce is actually outperforming the more homogeneous groups that we've had in the past. And that's something that should really influence how we select members of medical school classes and how we select members of residency cohorts. So many of you would not, if I said, what does a physician look like, look at this slide and have a physician that's a wheelchair user, this is actually a surgeon, be the first thought that comes to mind. But I want to challenge you to think about why. In my world, physicians are multiple amputees. Physicians are wheelchair users. Physicians are deaf and hard of hearing. And so that brings us to the question of, can a person with a disability actually become a physician? And so I want you to think about what your answer would be to this question. Things that I hear are, no, it takes hard work and long days to be a physician. Or yes, people with disabilities can add great value to our diverse physician workforce. Or, and this is most often, yes, but. And that but is really important because it defines what we think and it applies our stereotype to disability writ large. So yes, but only in some specialties, or yes, but only if they are able to overcome disability in order to be able to do the work. So we'll talk in a minute about what's feeding those buts. The reality is that thousands and thousands of physicians have disabilities across all specialties and across all disability type. You only see a snapshot here on this screen. We have physicians that are deaf and hard of hearing, physicians that are wheelchair users, physicians that have mental illness, physicians that have learning disabilities. In fact, there's a pretty high correlation between people with learning disabilities, dyslexia to be specific, and people that are surgeons. So we're investigating that. And who is part of this disability community? Well, the reality of the situation is that everyone is. So when we talk about diversity, we absolutely need to be grounding that in the identity of disability. Disability cuts across every single category of person that has been marginalized, and it can occur at any age and at any time. So any one of your trainees, any one of your peers could be a person with a disability in the future and will most likely be a person that has a disabling condition at some point in their lives. And this isn't going away. More and more people are disclosing disability. On this slide, I represent just my research alone. So from 2016 to 2022, our lab has shown that there's a 116% increase in the number of students with disabilities coming into medicine and disclosing disability. Now, what is that? How does that affect you as the GME program? Well, it affects you in a lot of ways, most of which is that all of these learners are coming up to GME and they will be disclosing disability. This is a post-ADA group, cohort of students that are really proud of being a person with a disability and what that brings to medicine. At the same time, there are multiple associations and organizations, and as we'll talk about in a minute, regulatory bodies that are having some more awareness of the value of people with disabilities as part of the greater diversity. The AAMC put out a report in 2018 encouraging both UME and GME to align their practices with what we knew at the time as best practices. Many schools did and many schools didn't, and training programs certainly had the same. We found about 40% of training programs were not compliant with ACGME regulations. But then in 2021, the AMA got involved and they issued direct recommendations for both UME and GME again. The language was a little stronger, and this time they were saying, look, you have to do something. People with disabilities are an important and underrepresented group in medicine, and we need to do our part to make sure that we're creating a safe and effective work environment and training environment for these individuals. And why are the associations and regulation bodies getting behind this? Well, because we know that there are multiple benefits to training and employing people with disabilities. Among them includes innovation, increased empathy, which we have a paper coming out that shows that, understanding of what it's like to be a patient, so that lived experience, resilience. You know, we talk a lot in medicine about wanting resilient trainees and resilient medical students and resilient physicians. Somebody that has worked with disability and had to navigate a highly ableist society and figure out how to make it work is somebody who's highly, highly resilient. They're also extraordinarily flexible in their thinking and in the way they approach things. They have this outside of the box thinking. People with disabilities are used to others trying to confine them to a space, and they navigate the world every day in every part of it. So they're used to having to think outside the box. And then nimble and creative responses. The other thing that is really, really important for physicians with disabilities is this idea of concordance. And I do want to say a few things about that. While concordance is really important, and we see some effect, especially among the African American population with regard to screenings, We do not want to pigeonhole people with disabilities into treating people just with their disability category. So in other words, we don't want to say that somebody that has the experience of mental illness absolutely needs to be a psychiatrist, or somebody that has the experience of a spinal cord injury needs to become a physiatrist. That is not what we're hoping for here. What we're hoping for is to infuse the physician workforce with a better understanding of disability writ large by having these experiences with people with disabilities. The concordance can come in many different ways, partially because of the trust that's built. And that's really the foundation of these concordant models, is that a patient that sees something about their physician that's like them is more likely to connect and to trust that physician. So again, we know that about the increased empathy, this informing patient care, facilitating shared decision-making, contributing to innovation, practicing concordant medicine in many different ways, and then entering primary care. Our research has also shown that physicians with disabilities are more likely to enter primary care, an area that's currently underserved. Unfortunately, there are multiple barriers in the pathway of an individual entering medical school, whether that's at the UME level or entering residency. Those include things like uninformed disability resource providers. So having the institution not have someone in a role of authority that understands disability and understands medicine. A lack of transparency. And I encourage all of you to go to your GME website and try to find information on disability. It'll be an interesting experience for you. So that's my challenge for you today. But lack of transparency. So where's the messaging? Do you have something on your website that speaks to the value of people with disabilities, that speaks to disability being part of the greater diversity workforce? And do you tell individuals with disabilities how to ask for accommodations and ensure their confidentiality and their safety in the process? So speaking of processes, the other burden is a burdensome or arduous process. And many times this process is a disincentive in and of itself for people to disclose, because you are reporting this to either your PD or a DIO or somebody who has a lot of authority and influence over your career trajectory. And then technical standards that are burdensome and at times can be discriminatory. Culturally, there are a lot of barriers. These include stigma, bias, a clinicalized culture. In other words, if you have a disability, everything that you do is related to that disability, even when it's not. We hear on our podcast people talking all the time about how as they're learning, and we know learners are learning, right? They're reaching milestones at different times, but that if a learner with a disability doesn't capture a procedure or a skill the first time around, that the automatic default is that it is disability related, even though they're a learner like everyone else, even though their peers may not get it on the first try either. And then restricted views of disability. So again, thinking that somebody with a disability cannot possibly be a physician, and negative peer attitudes. But overwhelmingly, the biggest barrier of all, as you can see in this line on this slide at the very top that kind of encompasses everything, is this idea of ableism and ableist beliefs. Ableism is discrimination and social prejudice against people with disabilities based on your belief that you must have typical abilities to be superior or to advance or to become a physician, right? And we're all ableist. I have ableist beliefs. I promise you, you have ableist beliefs. And I try every day to combat those belief systems by challenging myself, by really getting to the root of why I might automatically think something about a person. And that's across multiple different identities. But this is really, really harmful, because what happens is that we take people with disabilities and we put them in a box and we say, because you have this disability, you can only achieve so much. You can only be so much. And And that's where I want to encourage you, not only as a peer to people with disabilities, but in your role as pediatricians, when you're working with children that have disabilities. I was in private practice. I'm on my 4th career. I was in private practice for a very long time. And one of the things my partner and I used to say to each other and try to explain to others is we did a lot of diagnosing. I was a child and adolescent psychologist and did a lot of diagnosing of ADHD, learning disabilities, autism. No one ever brings a parent in and says to the parent, congratulations, your child has dyslexia, right? No one ever does that. We always get the sad, the very serious face and say, you know, that the study's fine, the test results fine, the neuropsych finds, and we go into a negative perception about disability. So we are partially to blame with what people take away from those meetings and how they contextualize their abilities and their disabilities. When the reality is, if you're a person with dyslexia, you are like 100 times more likely to be a millionaire. Why? Because you're more innovative, because you have to think about things differently. The people with dyslexia that I know are all cardiothoracic surgeons or surgeons of some subspecialty. So there's something there in the brain that allows people to flourish in other ways when there's a deficit. And we need to be really focused on that positive, that strengths-based model. Because the reality is that ableism is informed by people, right? Systems, structures, cultures, and climates, all it is people. We talk a lot about policies and we blame everything on policies and procedures and hierarchy, when the reality is we are the people making those policies. We are the people creating those structures. And if that's true, we can dismantle those as well. We have the power to do that. We have the power to take outdated and restricted views of disability and discard them and think, what's possible? Like, let's talk about what's possible. We don't know what's possible until we try. I think this is really the largest barrier to medicine, is that our own beliefs that inform these policies, practices, and structure and cultural barriers. So we do know some things from our research lab about residents with disabilities, and I'm going to ask you to be really thoughtful when we're going through these slides, because I'm going to give you some really severe consequences about people with disabilities that don't have accommodation. But what I want you to be thinking about as we go through them is, why don't they have an accommodation? What have I done? What has our program done to create a culture where people don't feel safe asking for accommodation or disclosing disability? So our lab does a lot of research, and one of those is a collaboration with the Intern Health Study, which you may have heard of out of Michigan, led by Dr. Srijan Sen. We added disability-related questions to this study, and it captures, I think, almost 20,000 residents. So what we found was that about 7.5% of residents disclosed disability. Most of the residents were disclosing things like ADHD or chronic health disabilities. And you can see the breakdown here on this slide. But what was really interesting to us when we started to look at outcomes and how these differed between 3 groups, that's the residents without disabilities, residents with disabilities who had program access needs met. In other words, they had accommodation for their disability and they were able to engage with the curriculum, engage in patient care, having those accommodations and removing barriers in the environment. Then there was another group we looked at, which is residents with disabilities that didn't disclose the disability to their program and didn't therefore have accommodations. And so as the slide depicts, no differences at all were found in residents without disabilities and those with disabilities who had their program access needs met in 2 outcomes. And these are important outcomes. One is an increase in PHQ-9 symptoms over the course of the entire intern year. So from baseline to 12 months. And then the other measure was self-reported major medical errors in the prior 3 months. So we asked residents to think back in the prior 90 days, and did they make a major medical error? Well, we know that interns make medical errors, right? So we expect some. However, the residents with disabilities who did not have program access were significantly different from the other groups on both outcomes. They were more likely to have an increase in PHQ-9 symptoms, so depressive symptoms, and they were more likely to report medical error. What does this mean to us? It means that access is critical, but belonging is also critical to success. And why do I say that? Well, we know that about 8.3% of medical students disclose disability. And this goes down ever so slightly to 7.5% when you get into residency. But when you go into the physician workforce, it plummets. It plummets to 3.1%. What's happening, right, in this space with attendings and physicians in practice that is keeping people out of the workforce? So we went over 3.1%, and that is the mistreatment of physicians with disabilities. So not only on the one end do we have policies and practices and structural barriers that we create that are keeping people out of the workforce, but then when we do let them into the workforce, we are mistreating them. This study just came out in Health Affairs, and it found that for physicians with disabilities compared to their non-disabled peers on measures of mistreatment, and I want to take a moment and ask you to contextualize this, right? Because we're looking at physicians without disabilities, but we know that physicians are mistreated across the board. So the baseline of mistreatment is already high, our comparison group. Now we're saying that physicians with disabilities are even more likely, and this really, our odds ratios were something like 6 to 17 or 18% more likely to be mistreated. This was across every category. So think back to that slide where I said everybody has an equal opportunity to be disabled, right? So this is across every category, including offensive sexist remarks, names related to sexual orientation, names related to disability, names related to personal beliefs, or identity, racial and ethnic identity. But also in this study, we found that physicians with disabilities were more likely to be physically harmed. Now, physical harm happens very infrequently, but it was 17 times more likely to happen to physicians with disabilities. It's pretty sobering when you think about it. And physicians with disabilities were also exposed to more unwanted sexual advances. A few years ago, 2019 or so, the ACGME decided that, look, this is a really important population and we need to do something to regulate what GME is doing with regard to the inclusion of people with disabilities. So they gave two regulations. One is an institutional-based regulation, and that says the institution must have a policy consistent regarding accommodations for individuals with disabilities, consistent with all applicable laws and regulations. Now, I encourage you again to go and look for your policy. I think you'll be very surprised. But there's also a program level requirement, and that is that you provide accommodations for people with disabilities. So it's twofold. It's program level and institutional level. One says you must provide accommodations for learners. The other says you must have a policy that tells learners how this process works. So what can you do? What can you do to make disability inclusion better at Stanford, especially in pediatrics? Well, you are literally the most important people in this equation. As we've talked about today, people are the ones making the policy. People are the ones driving inclusion. And the PD especially, and chief residents, are the individuals that are most likely to encounter someone disclosing a disability. You have to build a system of trust, right? You need to make sure that your trainees, the people coming in, feel like they can trust you and that you can then trust them to tell you what their needs are. Both parties are responsible for this. This requires you understanding the requirements, the regulations. What's a reasonable accommodation in GME training? So to aid you in understanding this better, the ACGME, in partnership with myself and two of my colleagues, created 2 modules. The first module is an overall module about the law and requirements. The second module talks about reasonable accommodation. Now, I could have taken those PowerPoints and given you that speech today, but I really wanted to motivate you to think differently. And I wanted to motivate you to be someone who wants to be a change agent in this space. All of these ancillary supports are things that you can engage in on your own or as a community. And I do encourage you to do so. These are very directive modules. So I think they're 25 minutes in length. And they give very, very specific examples of accommodation, very, very specific examples of the process and your legal obligation. You'll notice today I'm not talking to you about the law, and that really is on purpose, because if we are to aspire to meet the legal requirements of the law, we are not going to build a community that has a sense of belonging for our trainees. You know, following the law is just one aspect of why this work is so important. We need to not only want to follow the legal limits, but we want to engage with people because we know that there are multiple benefits. Again, innovation, thinking outside the box, empathy, lived experience as a patient. So in your program, I really encourage you to create a policy that can then be tethered to the institutional policy, and hopefully that will be changed. But I encourage you as the Department of Pediatrics to create a welcoming statement for people with disabilities, to encourage disclosure of disability, to speak to the privacy that you will ensure of the resident, that identifies an ADA representative for your campus, and list the documentation requirements that will be necessary to ask for accommodation so that people can gather things before they meet with this person. Again, reducing the time from disclosure to actually implementing accommodations. It's important to list the steps for disclosing disability and requesting accommodations. Be transparent. People want to know what to expect. List a projected timeline for accommodation review. It shouldn't take more than 2 weeks. In fact, the Office of Civil Rights has said multiple times, any request that takes more than 2 weeks is likely burdensome and unreasonable. Encourage early disclosure. When I talk to PDs and people in the GME space, they can't stress enough that early disclosure is what allows them to create an environment that's fully accessible for the trainee. But I want you to think back and remember what the trainee is dealing with. And so we live in an ableist society with ableist belief systems. That trainee is carrying a pretty extraordinary burden. And that burden is, do I bring my authentic self and risk bias, stigma, mistreatment? Or do I hold it all in and internalize it and not tell people? And as my slides earlier showed, there are severe consequences for that, both to the trainee and to the patient. And I would even say to the program in general, because if you have trainees that have higher levels of depressive symptoms and that are making more medical errors, they're very likely to not progress. And so you've lost a resident, which is a huge loss from a social perspective, but also a financial investment. Tell trainees how to appeal a decision. If something is turned down, there should be an appeal process. And then go a step further and take these new recommendations, these new policies and this language, and post it to your website so that any potential applicant can see how Stanford Department of Pediatrics is welcoming to people with disabilities. Place it in your house staff handbook. Review it during orientation. When you invite people for interviews to your program, make sure that you're asking them if they require any accommodations, and put a link to the policy and match information and these invitations. And then the process is really multifaceted to actually be following the law. It's an interactive process that is multi-step. One of the ACGME modules goes into this in great detail, and I just put it here for you to see, but we encourage you to really make sure that you're following that process, that you're not just, when you're doing accommodations, you're not just doing it on the fly, you're not just doing it informally, that you've codified everything for the resident. So there's a clear understanding between you and the resident and the institution of what the accommodations are, how they'll be implemented, and any other specifics that are needed. Disability is a part of diversity, and we need to make sure that that's the message we're sending. There should be disability-related information in all of your DEI or JEDI affiliation groups and affiliated activities, sorry. So make sure that it's part of your DEI or JEDI language, and highlight the stories of disabled interns and physicians. And I want to stop there for 1 second. I'm sorry to digress, but I've been going back and forth between person first language and identity first language. So an intern with a disability, a disabled intern, et cetera. I do that because there are two schools of thought on this. One school of thought, and most of the things that you'll read in the literature, because they're informed by the regulations of the journals or the type of language use that they require, is that person first language. So trainee with a disability, resident with a disability, and that's fine to use. But I also want you to understand that there's an entire group of people, disabled people, who are very proud of their status of being disabled, and they see and understand and want to express the value in their disability identity. And so they use identity first language, so disabled intern, et cetera. And so I go back and forth. I do encourage people, if you're not kind of situated in the disability space, it's probably safer to use identity first language. But I also think that whenever you're talking about any group, the best and most respectful thing for you to do is ask them. Ask people how they want to be referred to. Obviously, it'll be their name and whatever their preferred pronouns are, in almost every situation. But in those cases where you need to talk about a population, it's most respectful to ask the people how they want to be referred to. And so I go back and forth in both my research and in my presentations using both. Okay, so back to the topic at hand, the diversity, disability is diversity. Invite disabled scholars and providers to give grand rounds. So I'm here giving grand rounds to you today. I don't every day don't identify as a person with a disability, but I do have a disability. I have a chronic illness that will get worse over time. And so sometimes I do struggle with certain functional abilities, and sometimes I don't. So my disability status isn't forward as others, but I invite you to invite disabled scholars and others to present, and not just to present about disability. That's the other thing. These people are brilliant and doing incredible work in the medical education and healthcare space. So invite them to give talks about their work. And then ensure programming across DEI considers disability and intersectional identity. You can have people who are coming to this space with multiple identities that are causing exponential barriers in your training program. And think about access needs. I really appreciate that we have captioning today. Think about access needs in everything you do, including orientation, meeting spaces, and whether or not you are requiring meetings in person, or like today, you've allowed me to present to you remotely, because if I flew 3 times in a month, I probably would then be pushed into a flare, and it would not be good for my health. So I really appreciate that. There's other resources available to you, not only as a training program, but to all of GME. One of those is our program called DIGME, Disability in Graduate Medical Education. And it's a group, it's a community of practice that has worked to bring resources to GME. These resources include one-pagers, just-in-time kind of information for PDs. It's really geared towards PDs and DIOs, and then another group of information is geared towards the trainee. But we have these quick, less than 5-minute animated videos about the practice of disability inclusion. And one of the great videos that was created was called "Whose Responsibility Is It?" And it clearly outlines for both the PD and for the trainee that this is a shared responsibility, and that the trainee has to disclose disability to the program in order to get full access. One of the things that we have many programs doing is taking these videos and sharing them on their website. I think that's a great idea. It really helps you communicate to potential applicants or to current interns or residents what the process looks like, and that you are encouraging people to disclose. The other resource, and it includes somebody from your own home team, Dr. Peter Poulos, is the Docs with Disabilities podcast, where we interview disabled physicians and trainees. And we talk about the barriers, the accommodations they use, the bias and stigma involved in the process. But we also highlight successes. And this is a other great resource to link to your website. It highlights a lot of the successes of people with disabilities, which goes back to that myth busting, right? Again, we are coming to this from an ableist lens. We have to constantly challenge our perceptions and our assumptions about disabilities. But one of the greatest parts of this podcast is that at the end of each podcast, we give advice to people in the pathway. So this is to medical students, trainees, et cetera, but also to you as faculty and staff. So check that out if you get a chance. And then we encourage you to ramp up efforts to recruit and retain people with disabilities. Making that disability statement part of the recruitment process for your next cohort is really important. Linking to disability-related content on your DEI page or how you reach out to people about diversity is critically important, because the absence of disability in that DEI material is a message in and of itself to potential trainees and current trainees, and that is disability isn't valued. So your messaging is really important, but lack of messaging also sends a message. Share stories of disabled trainees on your social media page. Inquire with GME about funding sources for accommodation. You should not be primarily responsible for any accommodation for your department specifically. This should be a Stanford-wide responsibility. And then anticipate disabled trainees in your program and act like they're already there. Because I promise you, even if you ask today and one person tells you they're there, there's probably 4 or 5 that are not telling you. There are people with disabilities in your program currently. And expect more of people with disabilities and communicate that, not just to the leadership and your peers and to incoming individuals, but you are pediatricians. You have such an amazing opportunity to impact a child's life and their trajectory and the messages that they're receiving, because as a society, we're not doing a good job sending them messages that they can be healthcare providers. Even people like Target that are doing great jobs coming up with accessible costumes. You know, we're almost at Halloween season if you celebrate Halloween. And I've been so excited about all of the accessible clothing and the accessible costumes. But you know what costume isn't being touted as an accessible costume or a costume for individuals with disabilities? The age-old costume of dressing up as a physician or dressing up as a nurse, right? So we have a long way to go. I encourage you to contact me if you have any questions. My email is here. It's meeksli@umich.edu. Our lab handle is @docswith, and that's also our podcast handle. And then my personal handle on Twitter is Meeks Lisa. I will say I'm not on Twitter a whole lot, except for the lab. But I do try to share lots of relevant information and resources about how you can be more disability inclusive, especially on Twitter. So thank you so much again for the opportunity and for being so thoughtful about how I presented today. And I wanted to weave this into the talk because I think this is an expression of making sure that things are accessible to people. Not only have you allowed me to do this remotely, but you have captioning and you're allowing others to join remotely as well. And I really appreciate that.
All right. We have one question in the chat right now. What is the focus of disability for medical students at University of Michigan Medical School? As you today on residents?
Well, thanks for the question, kind of an unexpected question. So I'm not responsible for the disability office at Michigan. I actually am a researcher. So my work doesn't, my work applies obviously to disability inclusion at Michigan Medicine. And I hope that all learners are having a good experience. I know that I'm part of the admissions process, and we see lots and lots of learners disclosing and requesting accommodations, and certainly encourage that. We're admitting a ton of students with disabilities, so I'm super excited about that. But there is an office for disability inclusion and accommodation. And that office, I do not know how to pronounce the last name, but is now run by someone named JT. And I encourage people to reach out. But my research looks broadly at all, not only medical students, so UME and GME and into practice, but it looks at it from like a 20,000 foot perspective, if that makes sense. So I'm not doing an analysis of school level, individual level data, although I do have data for Michigan. And so it is something that I could look at internally and advise on if needed.
Thank you. There's another question about, are there sources that we could look at that other institutions have created about solutions they've come up with for disability inclusion?
Yeah, so in that AAMC report from 2018, they highlight 4 different schools and the different things that they're doing. One of the things that I say to people when I'm just talking to them in general is, look, no school is an exemplar. I can't say to you, go to this school and they are doing everything right, because we have a long way to go. I've been doing this for 15 years, and I'm so grateful about what has happened in the space, the movement we have had. And I think it's been a lot over 15 years, but we have a long way to go. And so I am uncomfortable holding any single institution up as an exemplar, because no one is doing everything right. And again, when I talk about policy, practice, experiences being informed by individual people, when you're trying to change the hearts and minds and behaviors of individual people, which hundreds and hundreds and hundreds, that takes time, right? That ship moves very slowly. So we're doing our very best to inform the practice on the ground. And I think the AMA report was just one more push for institutions to start to hire specialized DRPs, to codify their processes, to basically get their ship in order, if you will. And so I think we'll see even more improvements in the next 5 years.
So it sounds like, as I hear you speak, it's changing policies and procedures first, and then we see culture change years down the road.
Yes. And it's going to take, so one of the things I love about the students that are coming in now is they are unapologetically disabled.
Mm-hmm.
They know what they need. They've had accommodations in the past. They're going to ask for them. They're not going to carry the shame. I mean, some people will. So this is, but this is an overall general difference that I'm seeing in the cohorts of the past and the cohorts of today. And remember, I've been doing this for 20 some odd years. So I see a lot of differences in these 2 decades. And when these students show up, they demand equal access. And I think that as these learners come in, and as learners that have been disabled in this space go out to becoming attendees and being involved in academic medicine, that we will see a real shift in the way that disability is viewed in medical education across the entire spectrum. And it will be led by, these 2 groups, right? So that it requires some changeover in leadership, some changeover in the way that people think. And that does take time, but I do see that happening even now.
Thank you. Someone is asking, is there any data on violence against women physicians and residents by patients, aside from the data that you'd shared?
Yeah, so I also work, I'm really lucky to work with Dr. Elizabeth Vigliani at University of Michigan. We do a lot on sexual harassment and sexual violence. And so you can look up her papers, Vigliani, but there's a lot on violence and especially sexual mistreatment, harassment, and that kind of thing in the literature.
And then someone just wants to thank you for all that you do. They followed you throughout med school and her residency journey, and
Oh,
isolated as a disabled physician, and the work that you do has allowed her to connect with others who provide tremendous and valuable support.
thank you. Thank you very much. I know I get hundreds of emails, and it's hard for me to answer all of them. And when I do, I try to just give back to the resources. But if you check out our website, docswithdisabilities.org, we are in the process, we should have it up by December, of creating an entire resource page. And that page will not only take the podcast and delineate kind of the characteristics of each interviewee. So was that interviewee part of the BIPOC population? What type of disability did they have? Where are they in their training? So that people can more quickly find podcast episodes that are more related to what they're looking for. Their specialty as well. So if you're looking for a pediatrician that has a disability, and that disability happens to be being deaf, you could easily go to our website and find that. And so we're working on that, but we're also working on bringing all of the resources that are available to one space so that I'm not having to send people out to multiple resources.
And then I know there's a couple of questions in the room.
I am curious. So I know one of the big challenges that I've seen, at least as a resident, in terms of accommodations and more of a structural sense, is there's often this idea that taking care of myself or requesting accommodations or time off for something frequently leads to a greater burden on my peers, since
Yes.
that we don't, because in residency, especially the nature of inpatient work is an hour less of work for me means an hour more of work for my peers, which really leads to this just worsened shame and fear of accessing the services. Have you seen that in the data, and do you have any ideas of how to fix that?
Yeah, thank you so much for your question. It is a theme throughout most of our interviews. In fact, we did an interview with Justin Bullock and Jesse Gold, and it was kind of a no filters interview. And we talked about this, and we talked about how this is not an individual learner problem. This is a systems problem. And and here's where I'm going to get probably a little bit cheeky, but we're spending millions of dollars to build wellness programming when the reality is, and we have some data coming out from one of our labs that shows that, if you hire more people, whether that is hiring PAs or people to cover, to allow individual trainees to engage in self-care, which is wholly appropriate, right? And the ACGME requires the release of individuals to engage in that care. If you can create a system where that coverage isn't a jeopardy model, then the well-being of residents goes up. It increases. So the way we measure this, it's of course, it's all about the measurement, but it's a decrease in PHQ-9 symptoms. So I think that until we structurally address this by having appropriate coverage so that no one ever has to make a decision between their own health and well-being and the well-being of their peer, I don't think we're going to solve this problem. I think it's going to get worse and worse and worse, because what doesn't seem to be something that's understood by the programs or the kind of GME broadly is that the trainee in crisis knows that the other trainee that has to step in for jeopardy is in an equal level of crisis. And this may be the thing that pushes them over. And we're all terrified that, the just absolute consequences of someone hitting their limit are really deadly. So at any given time, we're not only carrying like this weight and burden of ourselves and can we take care of ourselves, but we're carrying an equal weight and burden of every single resident in our program. And do we dare ask for them to cover? And that's not a healthy situation. And I know that may not be a popular response, but it's my response. It's not a healthy situation. And we need to put individuals into the system to have coverage so that we're not relying on other trainees. And some residency programs are actually doing that. Some residency programs have a floating resident every single day so that if something happens, there's coverage. And some people have a PA that follows along the residency program so that if there's a gap in coverage, patient care is not disrupted. But thank you for the question. And yes, yeah, that feeling is fairly consistent.
Hi, Lisa. My name is Carrie Rosbach, and I'm our Pediatrics Residency Program Director. And I was very excited to hear your talk today because I feel like I have a lot to learn about how we can be more inclusive in our environment. We do have residents with disabilities, and we have in the past, and we've had some really incredible applicants with disabilities as well. And I have wondered how we could make our program more inclusive and welcoming. So thank you. You've given us some good ideas. I also think some of what you're talking about just highlights our needs more broadly in medicine to make a sustainable culture. I think even our residents that don't have disabilities, and as a faculty member without a disability, I sometimes feel like I have to be superhuman to do this job. Our jobs are so physically and emotionally taxing that it really can take a toll on all of us. So I wonder if we can bring in physicians with disabilities who can help us understand how to create more sustainable culture and structure in medicine. So thank you so much for the ideas that you've brought today.
Thank you.
Hey, Dr. Meeks, my name is Alok Patel. I'm one of the hospitalists also. What you mentioned about talking to families with dyslexia resonated with me, and I'm totally going to borrow your millionaire line. That's awesome. I have a quick question. From my experience of talking to some parents of children with underlying medical conditions, such as autism and dyslexia, I've seen there be a mix of some parents wanting to use the term disability, whereas others prefer something such as neurodiverse.
Yes.
Do you have a proper two-part question? Is there any consensus from your expertise about which term we should be using, or is it simply an individualized discussion? And then second, is there a better framework of talking to families about a new diagnosis? I respect what you were mentioning about not coming into it with such a dark tone. Is there another way that we should be doing it? And assume there is.
Thank you so much for the question. So I think, again, going back to that, respecting the individual where they're at, if you think about the labels that we assign to people, whether they're related to sexual orientation or gender identity or ethnicity, our brains work to really quickly assign a label to people so that we can understand a lot more characteristics about them, right? And I think we've gotten to the point in society where we say, boy, that's just really not fair, because what comes after that label is a ton of assumptions. But with those groups as well, people have to have a comfort level with what they're taking on, the identities that they're taking on. And so I would just encourage you to allow the person to decide their own kind of categorization or label. And a diagnosis is different, I think, from a general label. So a diagnosis of dyslexia is a diagnosis of dyslexia. Whether you see yourself as disabled or not is kind of a choice, right? To say, all right, well, I'm going to take on this identity or not take it on. And it's really interesting because I think there are people, especially in the work we do, we interview people that have functional limitation, but do not identify as disabled. And that's okay. We allow them to not go through life identifying as disabled. It's perfectly fine. Just respecting people where they're at. The second thing about, is there a better framework? I think always, especially with children, always focusing on the positives, especially for the child. A lot of times we're talking to parents, but the child is listening to everything that we say. And they're internalizing kind of how we're presenting information. And parents are hard, right? At least I know in my practice, it was really hard sometimes. The parents were more than seeing, the child. And so helping them reframe it too as a positive, or connecting them to support groups may be helpful.
Sanders in the general pediatrics. Curious about what we know about trainees who are caregivers of people with disabilities, and whether that's a child, a spouse, a parent, and how that affects.
Yeah, there's so many things that go on at the age of a resident. So it could be pregnancy, it could be caring for somebody that's a family member. You could have an older parent that you're caring for that's not disabled, but still requires a level of care. So I think that just the awareness that life goes on outside of the residency and how can we support residents, in general is really, really important. I think the other thing that you could do with that is the recognition of those particular factors, right? We won't know everything, but the more we normalize as a potential thing that might be an additional task on an individual trainee, helps the trainee talk about it, right? So if I have some things going on in my personal life, or I have a parent that's sick, or I'm caring for somebody with a disability, and I'm afraid to tell you because then I'm going to be scrutinized, my performance will be assessed with heightened vigilance. Like, I'm not going to tell you because I want you to think that I'm perfect. Because again, we've created this perfectionistic ideal. So I think the more we talk about things and just normalize things, the better off we are. I know that I owe my now, I think in the last 3 years, tendency to be less perfectionistic on a ton of women in medicine who just about 3 years ago came forward saying, I'm not perfect. It may look like it from the outside because we never talk about things, but this is going on and this is going on and this is going on. And just these women who were so accomplished and seemed so perfect, for them to say, no, life is hard. These are the things that happen, really allowed us at the time, I was a new faculty member, really allowed me and a lot of my cohort to say, oh, wow, okay. And it takes some pressure off. Like, we don't all have to be perfect. That's okay. It's okay to be human, and it's okay not to be okay. And I think that's the thing that we need to stress, because I think we would all agree that the biggest barrier to getting a resident where they need to be if they're in crisis is even knowing that they're in crisis. And we won't know that unless we create this trusting atmosphere where people feel comfortable talking.
All right. I'm going to bring this to a close. It was an incredible conversation. And as I was listening, and I appreciate one of the things you touched upon in the end about gender, there's also often it's the women that are taking care of the people with the disabilities or with other challenges. And there's some really interesting literature on how you create a culture conducive to the academic success of women is creating a space for women to talk about these demands that they're facing. So there's a lot that was great food for thought. This was really an extraordinary grand rounds. I think it's going to generate a lot of discussion and hopefully a lot of action. So I want to thank the people who came in person, and very much want to thank Dr. Meeks for joining us, and want to thank the Grand Rounds Committee for the vision of bringing this speaker to us. So thank you, everybody.
Thank you
Have a
so
good day.
much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.